USMLE style question on type 3 hypersensitivity. Question: a 28-year-old woman presents to the clinic with complaints of fever, joint pain, and a red rash over her cheeks and nose for the past 2 weeks. She also reports mild swelling in her fingers and intermittent pleuritic chest pain. Laboratory findings are as follows. Hemoglobin, 10.8 grammola, normal, 12 to 16 grams per. White blood cell count, 3,500 mmol, normal, 4,500 to 11,000 per millimeters. Platelets, 120,000 millimeters, normal, 150,000. Serum creatinine. Serum creatinine, 2.3 milligrams, normal, 0.6 to 1.3 milligrams deciliters. Urinalysis, proteinuria, RBC Cas, and anti-dsDNA, positive. Complement levels, C3, C4, decreased. Which of the following best describes the underlying pathophysiologic mechanism of this patient's disease? A. Cytotoxic T-cell-mediated apoptosis of endothelial cells. B. Antibody-mediated activation of complement against basement membranes. C. Delayed hypersensitivity reaction leading to granuloma formation. D. Deposition of antigen-antibody complexes in tissues activating complement. E. Mast cell degranulation leading to histamine release. Answer: D. Deposition of antigen-antibody complexes in tissues activating complement. Explanation: this patient has systemic lupus erythematosus, SLE, a classic type 3 hypersensitivity disorder. The presence of malar rash, arthritis, renal involvement, proteinuria, RBC Cas, positive anti-dsDNA, and low complement levels strongly suggests lupus nephritis, a key manifestation of immune complex-mediated disease. Mechanism of type 3 hypersensitivity in SLE. 1. Autoantibodies, e.g. anti-dsDNA, anti-Smith, form immune complexes with circulating antigens. 2. These immune complexes get deposited in tissues, kidneys, skin, serous membranes. 3. Complement activation via the classical pathway leads to inflammation, tissue damage, and recruitment of neutrophils. 4. Clinical manifestations include nephritis, arthritis, serositis, and vasculitis. Why not the other options? A. Cytotoxic T-cell-mediated apoptosis of endothelial cells. Describes type 4 hypersensitivity, e.g. graft rejection, type 1 diabetes. SLE is not T-cell-mediated. It is an immune complex disease. B. Antibody-mediated activation of complement against basement membranes. Describes type 2 hypersensitivity, e.g. Goodpasture syndrome, autoimmune hemolytic anemia. In SLE, antibodies do not directly bind to cell surfaces. Instead, they form immune complexes. C. Delayed hypersensitivity reaction leading to granuloma formation, seen in type 4 hypersensitivity, e.g. tuberculosis, sarcoidosis. SLE is not a granulomatous disease. E. Mast cell degranulation leading to histamine release. This is type 1 hypersensitivity, anaphylaxis, allergic rhinitis. SLE does not involve IgE or mast cell degranulation. Key takeaways for USMLE. Type 3 hypersensitivity equals immune complex deposition plus complement activation. Hallmark conditions: SLE, post-streptococcal glomerulonephritis, serum sickness. Complement consumption, low C3-C4, is a key feature. Nephritis and vasculitis are common complications. Would you like another question, maybe on type 4 hypersensitivity?